Just after 6 p.m. on the 4th of August, the city of Beirut was ripped apart by an explosion that could be felt 150 miles away. The centre of the explosion was Beirut's port, where nearly 2,500 tons of ammonium nitrate that had been stored in a warehouse for more than 6 years exploded. The result was more than 200 deaths and over 7,000 injured. The level of destruction resembled a war zone. Nearly 300,000 Beirut residents lost their homes, and hospitals and infrastructure were destroyed. Hello and welcome to this webinar, which is brought to you by the Disaster and Military section of ESTES, the European Society for Trauma and Emergency Surgery. We have 6 speakers who will be sharing their experience of dealing with this catastrophe and some of the lessons they learned. Dr. Jamal Hoballah is Chair of Surgery at the American University of Beirut Medical Center, and he will discuss the challenges they faced in the medical response to a non-conventional blast. Dr. George Dabar, Medical Director of Pulmonary Critical Care at the Hôtel Dieu de France, will tell us how they tried to organize the chaos. Dr. Bassem Safadi, Chair of the Department of Surgery at the Lebanese American University Medical Center, will talk about caring for the non-injured. Dr. George Juvelekian, the Chair of Medicine and Head of Critical Care at St. George's Hospital University Medical Center, will discuss how they combined caring in catastrophe with evacuating their hospital. These will be interspaced with case presentations by Dr. Ali Hallal and Dr. Jamil Borji from the American University of Beirut Medical Center. They will be joined for a panel discussion by Bob Dobson, an expert in pre-hospital care and major incident management, who's not only dealt with explosions in London over the past 30 years, but also helped to introduce and train paramedics throughout the world. With him will be Sten Lennquist from Linköping in Sweden, who's an expert on how to organize medical care in a catastrophe. There'll be a couple of poll questions during the case presentations, so please be ready to answer them. And please also use the Q&A button at the bottom of your screen to ask any questions that you have. That's a lot to get through, so I will hand over to Dr. Jamal Hoballah for the first presentation. Dr. Hoballah.
Thank you, Jonathan, and thank you, ESTES, for organizing this webinar. Almost 4 months ago, this catastrophic explosion rocked Beirut. It was called Hiroshima. It occurred in the hangar 12 of the port before and after, causing major destruction to the port and to the surrounding areas. At least 6,500 injured, 200 deaths, 600 to 1,000 disabled, many people still missing, more than 300,000 people displaced, property damage in 10 to 15 billions. All this is attributed to a fire nearby 2,750 tons of ammonium nitrate. Comparing this to other explosions, this is about 1,000 times more ammonium nitrate in the truck used in the Oklahoma City bombing. It's equivalent to dropping more than 100 mother-of-all bombs in the center of downtown Beirut. And it's about 10% of the bomb of Hiroshima. This is a map of the area. This is the explosion site. These are the various hospitals. This is St. George Hospital, where Dr. Juvelekian is. This is Lebanese American University, where Dr. Safadi is. Further down is Hôtel Dieu de France, where Dr. Dabar is. And this is where the American University of Beirut Medical Center, where Dr. Hallal, Dr. Borji, and myself practice. These are some common scenes from the explosion. These are scenes from the emergency room entrance, and these are some scenes from the hallways of the hospital. What I would like to do is share with you our response at the American University of Beirut, tell you what went well, what are the challenges we face, and the lessons learned. The American University of Beirut has been established more than 150 years ago. It went from a 200-bed hospital to its current multi-building medical center. As it happened, I was in the operating room around 6 p.m. I'm a vascular surgeon. I was being consulted on a tumor that was resected from the pelvis that was involving the iliac arteries and veins. The tumor was involving the vein, so the vein was resected with the tumor. The iliac artery was spared, but there was major oozing, and I was being consulted whether an iliac vein bypass should be constructed. Our operating room is made of 10 operating rooms, It's in the basement of the hospital. At the same time, there was a patient who had sustained a factory accident resulting in major scalp avulsion and who was being called to the operating room to have an attempted microvascular reimplantation of her scalp, 4 to 6 hour procedure. And as this is being discussed, a big sound explosion rocked the operating room. I thought must have been some gas explosion in the OR. A built-in closet from the adjacent room was pushed out of the wall and fell on the ground. We ran towards the OR desk. There were shattered glass on the floor. I was told a big explosion occurred by the house of the ex-prime minister. I called my wife, my son, no answer. Called the emergency department. The line was busy. Called the surgery department administrator to be prepared to activate the disaster plan. No answer, no phones. What would you do? Well, I tried my mother-in-law. She answered, reassured me that the family is okay. While I was doing that, while I was walking to the emergency department, I was told there was a huge explosion in the Beirut port and they were expecting mass casualty. I called the department assistant on the cell phone and informed her to call the faculty and activate the departmental disaster plan because our usual communication plans for disaster has not been yet activated. And at the same time, I have 3 ongoing cases in the operating room and 1 additional case going to be ready to leave the floor to the OR for that major scalp reimplantation. What would you do? Well, in our situation, we told the pelvic tumor case to pack the pelvis, do a rapid closure, and send the patient to the recovery room. In the remaining rooms, we told them, hurry up and finish. The scalp avulsion case, we put it on hold despite the huge crying and disappointment of the patient and her family. And we informed the recovery room to promptly discharge the stable patients and get ready for more OR and casualty patients. Started calling on the phone, on the cell phone, essential faculty members from all departments and specialties, trauma, general surgery, neurosurgery. Most were already on their way, and some of them already had showed up to the ER. Within few minutes, sirens and cars started showing up to the ER. Flood of patients delivered to the ED, including dead on arrival. Patients, family members, and transporters filled the ED, not wearing masks, screaming, crying in disbelief. Among the injured were friends, faculty members, and staff from AUBMC. And now we are having major registration and electronic medical record issues. We could not register many of the patients. Many of them did not have their IDs. What to do next? We delegated responsibilities. The trauma surgical faculty, general surgery faculty, ED faculty were directing the care, triaging who needs OR, X-ray, CT, and following the ABCs of trauma care. We switched to manual registration, writing on bed sheets and white papers. In the zones assigned to critical patients, 1 to 2 residents and nurses were assigned to each patient and responsible for staying with the patient until disposition. And we had our chief medical officer on site helping us with administrative decisions. The ED capacity is typically for 42 patients, and within the first 30 minutes, its capacity was exceeded. What would you do next? Well, we started using the hallways, opened additional locations. We opened the outpatient clinics and the medicine and surgery department on 2 different floors. We opened the outpatient minor surgery room. We opened the recovery room, used it as a pre-op unit and ICU unit. And we had prompt transfer to the wards from the ICU, stable transferable patients. Within the few hours, we received a total of 360 patients. 270 of them were treated and released from the ED. 108 were admitted, and we had 9 deaths on arrival. In the first 3 days, we had 68 operations in the main OR. 17 of them occurred in the first 6 to 8 hours after surgery. These first 6 to 8 hours, the operations that performed were 17 cases for life and limb-threatening injuries. The most of them were craniotomies for head trauma, 8. We had threatened limbs, threatened fingers, partial amputations, about 3 cases. We had some multi-trauma, including liver, kidney, lungs, one of them for liver and heart and head, and this is Dr. Borji, our next speaker will be talking about that. We had some major ophthalmologic and ENT cases. In addition, once the situation stabilized at around 11 p.m., we called back the non-explosion related emergencies, the scalp reimplantation, and re-explored the pelvic tumor case that had now acute limb ischemia for iliac thrombectomy and an iliac vein bypass. The following day, we took care of the more stable patient, the orthopedic cases. all type of orthopedic traumas from hip to knees to ankle, plastic surgery, repairs, tendons, etc. Ophthalmologic cases, we had one case with bilateral compartmental hypertension for both lower extremities from the thighs down. The following day, we had more orthopedic cases and plastic reconstruction for soft tissue injuries. And by the third day post-explosion, we were back to our elective schedule. We were able to resume some elective schedule, and we were dealing still with the plastic surgery and some orthopedic cases. So what were the challenges? Well, the basic thing is we've done a lot of disaster drills in our institution, but all those did not prepare us well for this. Patients arrived at a pace bigger than can be handled. They arrived with no identifying documents. Physicians, staff, friends were among the injured. We could not properly register the injured patients. The number of registration clerks were too few to accommodate, and our electronic medical system was not prepared for that. We had major uncertainty, not knowing what is coming next, and we had lack of central coordination within all the other hospitals. The injury type was variable, from brain out of head to major ophthalmologic injuries, extremities, and lacerations. The emotional shock and trauma to all involved was immense. We had major security issues and difficulty controlling the patients and relatives to the ED area. Patients and family were screaming. We had the death on arrival on stretchers were piling up on their way to the morgue, and very few of the injured or transporters were wearing masks. But in the middle of this, there was chaos, but no panic. We had some of the things we did well was the triage. We had experienced surgeons of all specialties and ED physicians deciding who needed to go to the OR, who needed to go to CT scan and X-rays. We had a prompt management of lacerations using skin staples, and importantly, prompt discharge of stable patients from the unit, from the ED, in anticipation for more arriving patients. We did well with managing the resources from staff and facility. As far as staff, we were able to get the surgeons available to the AUB, to the hospital. We even brought one neurosurgeon on a motorcycle, because at one time we had 3 neurosurgery operating rooms going at the same time. We had a radiology attending available in the reading room, helping us in major decisions. We used all the possible facilities at AUBMC, separating patients into zones by severity. We used the recovery room and the ICU as prep and opened the outpatient clinic. As far as safety, we did good by double checking the X-rays and the patients, making sure that the X-rays were appropriate for each patient. We had a senior surgeon rounding and double checking again and again for any missed or delayed injuries, and we provided PPEs for staff protection. Some of the things that went well were direct and strong communication back and forth between us and the operating room, nursing, and anesthesia. We dealt expeditiously with the existing cases, and we set the priorities in the OR and stopped the elective schedule for the following days. And we're very proud that we were happy to be able to care for the non-explosion related emergencies. This is that lady after her scalp reimplantation, and this is the lady with the tumor after the multiple plastic reconstructions. What are the lessons learned? Well, there are lessons learned in planning and implementing your disaster plan. In the planning, your disaster plan should anticipate an overwhelming mass casualty, should anticipate inability to use regular communication channels, cell phones, etc. You should be able to deal with the routine disruption of patient registration and identification processes, and use the simplest forms of identification, including writing on white piece of papers, writing on the bed, or even writing on the patient. Disruption of usual OR facility should be anticipated. Your OR may get injured and blasted, and you need to have availability of alternate OR facility. You need to be able to preemptively allocate various areas for different level of injuries, and you need also to be prepared to evacuate your hospital. In the implementation, you need to have expertise in triage and decision-making in the ED. You need to have senior administration available on premises to help you with key decisions for space and resource allocation. Prompt staff mobilization is essential, and prompt and immediate communication with all the team is essential. And you need to be prepared to improvise as needed. In addition, in the middle of all this, you need to ensure security and staff to all your staff members. Important things is in the aftermath, you need to promptly replenish your supplies and resources, and cannot underestimate the psychological and socio-economical support for the injured and non-injured that is needed. At the same time, you need to have careful monitoring of any potential missed injuries or injuries that need further care that were not cared for during the event. We don't wish this on anybody, and we certainly hope to rise back and have you visit us one day in the good old days of Beirut. Thank you for your attention.
Thank you very much for an excellent presentation, for a great experience that I think we all wish you didn't have. Can I ask you a question? You said that you were overwhelmed with more patients than you could deal with. What were the sort of bottlenecks in the system that really stopped the flow of patients?
Well, space is one thing, and this is where we really had to allocate and create and generate space, and that was the most essential thing. As far as staff and faculty, we had immediately all our faculty members and people came from everywhere, even faculty or even physicians who had left AUB, fellows who had trained at AUB and had left. They spontaneously, people were coming from everywhere, even nurses that were no longer worked with us came to help. So I think we were able to deal with the human resource factor. The major bottleneck was space and allocation of space and resources appropriately for the injured patients.
Okay, thank you. Sten, did you have a question you wanted to ask?
Dr. Hoballah, congratulations to an excellent presentation, really. And thank you for sharing your invaluable experiences with us. That will be a great help, I think, for all of us. Lebanon is well known to have an excellent standard of medical care also from international point of view. But on the other hand, your country has been suffered from socioeconomic problems for some time. You are middle in a pandemic. Some of your hospitals were blown out. So the way you handle this huge disaster, unique in its kind, is really impressive. I have a question to you. You said you had around 200 deaths from this disaster. How many of these 200 patients were really dead already before arriving to hospital? And how many died in hospital? Do you have any information of that, your in-hospital mortality?
In our hospital, the death on arrival were 9 patients. The other deaths, we had about 5 deaths, and 3 of them were related to neurosurgical injuries that were very overwhelming. We had 1 death related to multi-trauma, and another death that was not very well identified. We thought it was mainly an additional head injury, because this is a patient who died while being monitored in the recovery room in preparation to determining what step to do next. So overall in Lebanon, though, I don't have the good number of of the deaths, how many arrived, death on arrival for the entire statistics of Lebanon. So what I shared with you was what happened at the American University of Beirut.
Okay, thank you. It's still a very low overall hospital mortality with this huge number.
Yes, I would like to comment here that one of the major type of injuries that occurred was related to glass injury and breaking of glass. The explosion effect of the immediate explosion in the immediate area, that resulted in a lot of immediate death in the area. But many of the other injuries were related to glass and shrapnels and things of that nature. I also want to mention another major block we had was the registration of patients in the presence of a electronic medical record. We had recently implemented 2 years ago a very fancy electronic medical record, and although it is a great thing, I think this was a major bottleneck at the beginning in terms of dealing with the patients. And this is where, you know, when you have something like that, getting off the medical record electronic and just go by the standard paper and writing on papers, etc., the simplest form is a key thing in caring for these patients.
Thank you very much.
Bob, you want to make a question?
Yeah, thank you for a very good presentation. I just wonder, where were you getting the information from scene from? We've had a blast here in the UK recently where there was only 3 casualties, but it was a big blast. So how were you getting the information from scene about how many patients you were going to get?
I think this is another important aspect that we did not have a good information. We do not have a central communication center that can coordinate these things. So typically it was a direct communication between the emergency department director and the Red Cross. So it's communication between us and the Red Cross, communication between us and the firefighters, and this is how the main communication that we were getting information from the scene. So these two sources were the ones providing us with information. And this is another lesson learned, is that for every country, every center should have a clarified center for the entire area to coordinate care, so that we know what to expect. You can then figure out where you can divert and how you can and where to divert. And I have to give credit to a lot of the surrounding hospitals, because a lot of the surrounding hospitals, we have many of them, carried a lot of the load for taking care of the other injured. So those that were very badly injured came to the major centers, and those who felt that they could go to further hospital, they went, some of them, to hospitals 20 kilometers away to get their lacerations fixed or few other things taken care of. But that's a very good point and very good question about the coordination of the casualty and information that has to be shared with all the hospitals so that they know what to anticipate.
Thank you very much.
Okay, thank you. I think that we could answer questions, we could give you questions all night, but I think it's important that we move on so that we can get through other fantastic presentations. Thank you very much for your presentation. Please stick around for the discussion.
Thank you.
Ali, can you share your screen and give your presentation, please?
In the meanwhile, Jonathan, there are really many questions to Professor Hoballah. If possible, can you reply to the question and answer? Because some of the questions are really very interesting.
Sure.
Thank you.
Sorry, are you asking me to answer directly the questions that I have on the chat?
Yes, please.
If you could write the answer, if you could type the answers in, that'll be great. Thank you.
Yeah, I will type them and send them if you want, and then you can proceed with the presentation. That'd be easier.
Yeah, sure.
That's great. Thank you very much.
Sure. Sorry, are you waiting for me to reply to these, or you want maybe?
No, waiting for Ali to share his screen. There seems to be a problem.
Yeah, that's a relief. I'm gonna mute my microphone and I will type the answers.
Thank you.
Thank you.
Can you see it, Jonathan?
Yes, thank you very much.
All right. I want to thank ESTES, and I want to thank you, Johnson, for giving us the opportunity to present our experience. I'll be presenting a really small case. This is a tracheobronchial foreign body aspiration resulting from the Beirut blast. So the patient is a 70-year-old male who was actually in another hospital, a sister hospital, and then he was admitted on an elective basis for a curative surgery for laryngeal cancer. He had a laryngectomy, which was complicated by a fistula, and then he needed the pedicle muscle flap to treat that. He had one perioperative cardiac arrest, and he had a really bad heart. His ejection fraction was estimated between 35 to 40%. On the day of the blast, he inhaled glass through a wide tracheostomy, through the tracheostomy stoma. And then at that hospital, which was badly damaged, there was no capability to treat at the admitting hospital. However, he had minimal respiratory symptoms. So the UBMC, the American University of Beirut Medical Center, received the call on the next day after the explosion. This is his CT, and these are two coronal views. And you could see on the left-hand side of the screen, the foreign body, which is adjacent to the tracheostomy. So it was lodged between the tracheostomy and the tracheal wall. And on the right-hand side of the screen, you could see another foreign body, which is further down in the right main bronchus. So my first question is that taking in account the aftermath of the explosion and the fact that we were working at full capacity and the patient had minimal symptoms, would you transfer this patient to a tertiary center? Yes or no? Okay, so I would like to hear the opinion of Professor Dobson and Professor Lennquist on that issue, whether we should have transferred a patient who had a curative surgery, and then we are practically one of the tertiary hospitals that can provide further care to that patient.
Well, if I should answer first, that's depending on the clinical condition of the patient. I mean, this is an example of a very advanced treatment in the middle of a mass casualty situation. But if you have the facilities, and I understand you have good facilities for treatment, also for ECMO here in Lebanon, and then of course you should do it if there is a possibility. But if the patient is stable, maybe you don't need to transfer him during the middle of the high mass casualty load, but can wait 24 hours or 48 hours until most of the severely injured have been taken care of. But if you can save him and have the facilities, of course you should do it.
Right, Professor Dobson?
Yeah, this is more of Sten's expertise than mine, but yeah, again, I agree with Sten. If you've got the facilities to do it and you've got the capabilities to do it, then yes. But you don't really know what's coming at you for the next few hours. So it makes it a very big decision transferring people.
Yeah, so we deliberated about, thank you for the answer. We deliberated about this issue. We knew that it will take a lot of resources to transfer this patient and then to treat that patient on the next day. But we elected to do it after anyhow. So we took the patient, we got the patient and we repeated the CT scan. We checked that there was no major problem beside the information that we had. And then we decided to take the patient to surgery, and then with an attempt to remove the foreign body by bronchoscopy. The patient could not tolerate that because of his bad heart. So what to do next? So we thought about the process, and then we have the facility to provide ECMO. So we called the cardiac surgeon. This is Dr. Jamil Borji, who's speaking next. And we decided to put the patient on VA ECMO, and that allowed us to remove the tracheostomy and to do a bronchoscopy in apneic state. So I'm going to share with you a video of what we have done, and that was on the second day or third day of the problem. So here, the ENT surgeon. So we approach it from a multidisciplinary approach. This is the ENT surgeon who's trying to go all the way into the second, third radical. You could see that the glass wasn't as deep as that on the initial CT, but actually it went further down. he could not reach it, so he innovated. So he got a suction, and then he applied a bit of suction, which brought the glass 1 to 2 centimeters more proximally. And then he attempted again to grasp the glass successfully. You could appreciate the depth of the inhaled glass. So we were able to retrieve actually 4 glasses. Lesson learned. I think we all had the same experience that explosion in urban area, you should expect a significant number of glass-related injuries. We did not see a lot of patient with major blast lung, blast bowels, because most of these patients actually died because of the vicinity of the explosion. They were all beside the ground zero. But we saw a lot of patients with fracture and then glass injury. Should always be careful that the diagnosis of tracheobronchial foreign body necessitates a combination of radiological and bronchoscopic evaluation. We all know that it's more common in children. However, it can happen in adults. We should be careful that some of these foreign body can be radiolucent. And this is why you need to interrogate it with a bronchoscopy. It is a serious issue. It can cause to irreversible damage in the long run. However, in the short period after the inhalation of these foreign body, you can have bleeding, pneumonia, or perforation. And this is why it's important to intervene early. It is a combination of rigid and flexible sigmoidoscopy. It should always be done with, through a multidisciplinary approach. We found that ECMO can significantly be helpful in this type of injury. And I think as a last point, I think in selected patients, the disaster plan should include the capability of transferring selected patient to tertiary hospital if that hospital can provide care. Well, I thank you for giving me the opportunity to present, and I'm happy to answer any question you might have.
Okay, thank you very much. I think we'll save the questions for the end discussion. And if we can move on to Dr. George Dabar with his presentation on organizing chaos.
Someone is still sharing his screen, so I cannot share.
All right. Okay.
Okay, good evening. Thank you, Jonathan. Dr. Hoballah, thank you for the nice presentation. So I'm going to share our experience from the Hôtel de France point for organizing that messy night on August 1st. I'll start with a summary. Well, on August 1st at 6:10 p.m., I was in the hospital and a massive explosion blasted to the wall of Hôtel Dieu, which is 2.5 kilometers away from the blast epicenter. All alarms in the hospital went on. We stepped out of the room. We were in the meeting room, realized that the hospital itself suffered. Windows were blown off, the ceiling were down, all wires and cable fell in the hallway. Looking at the sky, a red cloud engulfed the whole atmosphere. Initially, we thought it was a plane bombing, actually. At this point, we were not aware that approximately 2,700 tons of ammonium nitrate stored in the port of Beirut ignited and set off a massive blast that destroyed a large part of the city. We ran to the ED to assist our emergency physicians, and at 6:25, the first injured patient was in. Just to give you an idea, this is the epicenter, this is the blast, the port area, this is where Hôtel Dieu is, the red circle, and this is the closest hospital that is nearby. The closest hospital to the scene, the 3 major hospitals were down. We were not aware of this. We were not even sure that it was the blast at the port. So we were not aware that 3 major hospitals in our neighborhood were down. The Red Cross, Lebanese Army, and TV news station mentioned the horrific scene on ground zero. So we were tuned to the TV to know what was going on in Shil. As the Hotel Dieu capacity that day was for 400 beds, 70% were occupied on that night of August 1st. The decision on the surge capacity had to be taken immediately, where the central command formed by the CEO, the CMO, and the head of nursing, luckily on the site that night, decided to go immediately to a red level disaster plan that was activated, which was the Plan Blanc in French. The immediate decision we took, one was to shut off the alarm, two, to evacuate the emergency room department and discharge patients home or to the medical ward if needed, arrange for extra human resources, secure the access to the emergency department, the disaster plan red level broadcast on the cell phone of all the personnel of the hospital or employees, biomedical injuries to check the functionality of major equipment like the CT scan, the O2 supply. In the surge capacity, we look at the human resource, the equipment, and the space. Immediately, we called on more nurses, surgeons, and residents. Actually, they came in spontaneously. The equipment, stretchers, suture material, pain medication, sedative was channeled to the emergency room, and the emergency room extension was planned already looking at the post-op areas and the family area also, where we had to find places for those. The way we looked at the priorities, first we had to have a clear decision maker, which was the CEO of the hospital, the head of the emergency room department, and the chief medical officer. And then we had to organize our triage area and the ER access. We got all the OR rooms ready with anesthesia, surgeon, physician, and resident. We broadcast all employees on their cell phone to join the hospital. We made sure the radiology technicians were on site and the CT scans were functioning. We organized patient listing and identification, and I will get to that later. The blood bank supply and the pharmacy supply, the central command organization, and our communication. The secondary priorities were to secure the triage area, dispatch medical resources within the emergency room, and identify the red, yellow, and green zones. To verify patient identification, it was really tough. The protocol for record keeping are very important because everything will follow on your health information system, in the CT scan, in the operating room, and that was really complicated because now hospitals are, health information systems are fancy computers, and then you don't have the time to enter all those data. All victims must be identified and tracked through the system. Then the next priority was to open up the day hospital, all ambulatory area, secure surgical kits, sterile gloves, and blood bank supply, and know the limits of our team. First of all, organize the triage. Well, we have to know that Lebanon has no EMT service. No triage is made on the blast field. So the triage checkpoints were made outside the emergency room department. The space in front of the ED was emptied for ambulance access, and the security personnel oriented walk-in ambulances, car, media, and visitors. And this is the floor plan for our emergency room. Usually cars come in here, ambulances drop off patients, and this is the main emergency room with the trauma area, pediatric area, and other boxes, and this is usually the triage area. This is the outpatient building, and then what we did, the green area was for minor stuff, the red area for all the critical patient, and the yellow area for the patient that could wait a little bit. And the security was put here, and our triage area was put next. And this is how it was organized: a red zone for the critical area, the yellow and the green zone, the yellow for the walk-in, and the yellow for the one who could wait a little bit. And this was managed by the ER doc, emergency room nurse, and helpers. So this is where we put our triage outside the emergency room, and the oriented patient, the walk-in would go to the ambulatory area, outpatient ambulatory area, and this is the triage area that could take 10 patients, and triage, all triage, but now it was for the injured, and those 20 patients that we could be taken in the critical area was the pediatric area. And as we open up the endoscopy suite, which was on this side for minor injury, and that could take also 10 patients. And the security guard would orient patient here, cars and ambulances here, and go back out so we don't clog the system. It was important to streamline the triage in emergency room. Actually, the walk-in would arrive first by themselves, so the less severely injured would come first, and the second wave will come with the most serious. So it was very important to get those less injured out of the way. And the simple triage tool we used, so that was simple. As the patient could walk, we'll go to the green area. The patient was not spontaneously breathing. We send it to the black area to a short CPR and make sure if they were diseased or no. And this is before getting in the emergency room even. And now if the patient had a respiratory rate that was more than 30, or a blood pressure that was low, or a Glasgow that was going down, he went immediately to the red area. Otherwise, he would go to the yellow area. So what was important was not to under triage because we'll be run over by the patient inside the emergency room. And this is how, at one point, how our emergency room looked at. So there were no more space to put patient. Actually, the capacity looked like that. The ER, the main ER zone, which is, we gave it the red zone or the polytrauma and critical. It was staffed by critical care physician, anesthesia, cardiology, general surgeon, and pediatric critical care and junior surgical resident. And the ratio of doctor to patient was 1:2, and the ratio of nurses to patient was 1:2, and that was for 20 beds. The yellow zone, which was the old triage area, was serious patient but could be delayed. It was staffed by surgery resident, emergency room attending, and the ratio doctors to patient was 1:4, and ratio to nurses to patient was 1:4. It was for 10 beds. And then the green zone, which is outpatient minor surgery area and GI endoscopy suite, minor injuries, suture, wound debridement, etc. The medical specialty attended there were GI, ID, cardiology, and the ratio was 1:2 with 1 nurse to 4 patients, and that was 15 beds. So the total at one point, we could have around 45 patients. The OR setup, well, the chief of the OR, the head of anesthesia, she coordinated with the emergency room, the admission, and the radiology. We had to stop all scheduled surgery. We evacuated the recovery room, and surgeons were there. They came spontaneously. We had 4 orthopedic surgeons, 3 neurosurgeons, 2 vascular thoracic surgeons, 2 ENTs, 3 plastic and facial surgeons, 2 general surgeons, and 2 ophthalmologists. Anesthesia nurses, scrub, and circulating nurses, and anesthesia residents made 10 rooms functioning. We have an OR with 13 rooms. We were having that night 10 rooms running till the morning. Obviously, we stopped all elective surgery for the next 2 days because as you will see later, a lot of the patient had to have redo surgeries. And this is, I think, very important in this kind of situation where patient would come unconscious without IDs. And what we did, each patient had an ID card on his stretcher or neck after crossing the triage. And that was put immediately after the triage, where we identified the area that was injured. And then finally, a nurse will put the vitals, and then it goes with the patient to radiology, where we put the finding, etc. And what we did in yellow, there is a serial number, and those serial numbers are pre-prepared and put in a safe in case of a damage that could happen to the system, and they will roll on one after the other. So we know it's a special serial number for any disaster. All red patients were accompanied to CT scan with an MD, and 1 or 2 doctors managed the CT scan area for patient surveillance because there was a huge queue in the CT scan and patient could deteriorate down in the CT scan. We had finally a crisis room where we identified the different sector of the hospital. That room was connected basically with Wi-Fi, TV screens, and communication tools to deal with the outside, with the Red Cross, with the medias, with the Lebanese army and the security agencies. And finally, this crisis room also was dealing with the supply of the hospital, with the major structure of the hospital, with the radiology department, the OR, and the other part of the hospital, mainly the waiting room to get the social area, a priest, etc., to attend the families. Just to remind you that the blast, at the epicenter, you get a lot of blast injury. What we've seen mainly are what's in the secondary and the tertiary area, basically penetrating and non-penetrating injury. And projected injury, mainly kids had a lot of projected injury. They were blown off to walls, to tables, etc., and had some trauma. This is where the neurosurgical trauma came from, basically the head trauma came from. So we've seen 138 patients that were identified, treated, and released on-site for suture and wound care. The average age was 44 years. 97 patients were admitted with an average age of 47. 69 had at least 1 surgery. On average, each patient had 1.7 injury, and 3 subsequently died. 13 were declared dead in emergency room. 200 plus treated on the ER sidewalk for minor injury and wound debridement, not accounted for in our medical records. And this is how it looked like on the sidewalk, basically attending light wounded patient. Those are residents taking care on the side of the emergency room sidewalk. So basically 248 patients were identified on August 4 and 5. 200 were treated on the sidewalk. 97 were admitted, 13 were pronounced then in emergency department, and 138 treated for minor injury and released. Of the 97 admitted, 69 had surgery, or 71%, and 3 died subsequently. All of 3 had head trauma, and 37 had follow-up surgery, or 53%. At one point, this is how our emergency looked at, and you can see a lot of the injury were to the limbs, upper extremity, lower extremities. And you can see from our statistics that almost 50% of the injuries were orthopedic, followed by head trauma, intracerebral bleed, subdural hematoma, brain contusion, etc., and facial and plastic surgery. And all this is coming from the glass, the broken glasses in the building, and that was really flying all over. In conclusion, every disaster involved a unique set of circumstances in terms of etiology, environment, casualty load, available medical resources. Planning and execution of medical care may contribute to maximal casualty survival, and we did some rehearsals. Since 2006, we had 2 or 3 plans that we updated, and that helped us. Planned rehearsal is determined in managing such a disaster. Leadership is important to orient people, and voluntary work are the essence. None of us is ready to care for over 400 wounded in a 12-hour interval. Thank you.
Thank you for that fantastic presentation. Let's ask the panel if we have any questions at this point.
Yes, I think you should call your lections organizing chaos. I think you should call it eliminating chaos, because that's exactly what you did by an excellent performance, exactly according to the book. I think you are only to be congratulated. I have one question for you. Which factor did you identify as the major limiting factor for research capacity? Was it the emergency department? Was it the access to theaters? Was it the access to ICU beds or beds in general, or access to supplies? What did you identify as the factor limiting the capacity to receive patients in your hospitals?
The capacity, actually, suture kits were missing at the end of the night. At 6 o'clock in the morning, after running this thing for 12 hours, suture kits were running out. We were stapling people right and left, basically. The human factor, people were getting tired. Operating room was running on for 12 hours non-stop. But I think at one point, and unfortunately, we had to close the door of the hospital, because you're seeing the picture. You had to attend for all the people that were around you. And we had to call on the police and the army to block the door of the hospital.
And what do you think was the main reason for that? If you prepare for the next disaster, what factors would you specifically work with regard to supplies, to staff, to equipment for the next time, for the future?
I think for the supply, it's not the issue. I think nobody expected that you will get this, that you would have to take care of such a high number of casualties. It's beyond the number. Lebanon's been through war, through a lot of car bombing 30 years ago, and never in the history any of our emergency room at our side or an American university side had to care for so many people. So organization is very important. I think this is overboarding organization. As much as you are organized, your human capacity will not be able to handle. Because patient walk in, even minor injury, were coming to you, while in a country like North America or Europe, they will be handled on the field. There will be a lot of the minor injury could be handled on the field. So you had, when the patient is within the premise of your hospital, even you have to take care of him. So you have to have human resources put at his service, plus you have to put human resources at the service of the most critical. So I think the limiting factor we had is that is the human factor, is the load of the people. It's not the equipment. It's not the room in the operating room. It's not the capacity of the surgeon. It's not the capacity of CT scan. By the way, one other thing I would say, in such a crisis, you need 2 or 3 CT scans to avoid delay, and which no one of us would have in his hospital, to have 3 running CT scans. The queue at the CT scan took 45 minutes. When you have a head trauma or abdominal injury, waiting for half an hour to get your CT scan because you're just having patient after the other scan, it gets you complicated things.
Thank you very much.
Jonathan, is it okay if I ask a question, Jonathan?
Sure, please do.
Yeah, George, excellent presentation. I have one question. I'm not sure if you alluded to in your presentation. Short of a national blood bank in Lebanon, we had problem getting blood on time. Did you have the same problem at your hospital? I mean, at one point in time, we had one patient that we needed to transfuse, and we were giving fluid just to maintain hemodynamics instead of transfusing with blood. Did you have the same problem at your hospital?
As far as I'm informed, we didn't have that problem because donors were coming left and right, basically. And the blood bank worked all along. Plus, we have already a large stock of pouches here. I may say, just going back to Dr. Lennquist's question, the most difficult thing at one point was patient identification. Because can you imagine, we had 2 patients in the OR that family were looking at all over Lebanon to find them the next day in our operating room. They were brought unconscious with head trauma, and both of them survived.
Okay, I'd like to ask a couple of questions.
Okay.
Yeah. Can I ask a couple of questions here?
Please do.
Yeah. Okay. It looked like a very impressive crisis room that you set up there. How quickly did that crisis room come into play?
Actually, in that, we had a meeting with a lot of the players in that crisis room just before the blast. So all the actors went down to the emergency room and then went back to that room, and then it builds up over the hours. So everyone was not there just at 6:30 or at 7 p.m. So it built up to 8 or 9 p.m. and everybody was running. But we pre-identified each person in charge in every sector, so we could coordinate from that room. One of the things we had one day is we were afraid of having lose our communication tool. So we had ready even special phones for the hospital basically to use. We were worried about not having. In our plan, actually, we identified 2 or 3 areas where we could meet, because as my colleague, Juvelekian, will discuss later, if the hospital was hit, that would be a big issue too.
Can I just ask one question around that again? And that is that the crisis room, was it looking just internally? Because you said earlier on that the coordination with the other hospitals, you weren't aware that the other hospitals were down. So is that a role for the crisis room, or have you got a specific people that got to find that information out?
We got that information from the Red Cross, and we got this information from the TV. This is why we have a TV in the crisis room.
Yeah, perfect. Yeah, thank you. Thanks very much. Great plan.
Okay, thank you very much, George. Thank you, Sten and Bob, for your questions. George, do you want to address some of the questions on the Q&A session by typing those in? And if we move on to Jamil Borji for case presentation.
Okay.
Is my screen shared?
Perfectly, thank you.
All right. All right, I would like to thank the European Society for Trauma and Emergency Surgery for the opportunity to present. I will just disclose then that I'm a thoracic surgeon, not a trauma surgeon. So maybe some of the things that you will comment on, you will take into consideration that fact. And I will start by reiterating that on almost 4 months ago on August 4th, a large amount of ammonium nitrate stored at the port of Beirut exploded, causing at least 200 deaths, 6,000 or more injuries, billions of dollars in property damage, and also leaving an estimated 300,000 people homeless. AUBMC, or the American University Medical Center, located within minutes from the epicenter of the explosion, suffered significant material damage, not nearly as much as bad as other hospitals, and I believe Dr. Juvelekian will go into details about that. But also it turned within minutes into a major trauma receiving center. ED staff were joined and assisted by physicians from multiple specialties, like Dr. Hoballah described. Wounded patients were treated. Those who needed operations were taken to the operating room. Many were saved, and some were not lucky to survive. I'm going to present a case where patients sustained a multiple trauma, and the purpose of that is to analyze the response, the diagnoses that were formulated at that time, and the management plan in the midst of all the chaos that was described. So this case is about a young man who was brought to the emergency room within minutes of the blast. He was placed into an exam room, and I'm saying that just because other patients were treated in hallways or on chairs. And according to the report that we got from the primary survey that was done by ER residents, he was awake, oriented, with a question mark about his orientation. He was moving 4 extremities and had a vital sign that were near normal, with a blood pressure of 110/90, a heart rate of 110, and a saturation of 97% on 2 liters of oxygen. He had minor bruises over the chest and the right upper extremity, and he had a significant posterior scalp laceration. A fast exam was performed and was reported to be negative. So the management at that point was to place a large bore IV and administer 1 liter of IV fluid and request a full body CT scan. And here I think Dr. Dabar mentioned the importance of CT scans in trauma centers such as ours in situations like these, because the wait time for CT scan was really, really long. And here the team moved on to see other patients. And I'm not sure about the time period here, but I was walking in the emergency department, and I saw that patient, and I found him to be agitated. His skin was clammy, and he had cold extremities. His blood pressure was 80/60, and his heart rate was 130. So again, we called the nurse that was around and gave him another liter of fluid. And the ED physician at that point presented and performed a second fast exam, which revealed a significant pericardial effusion with minor fluid in the Morrison pouch, described to be 2 centimeters in thickness. So we immediately tried to get him into the operating room, but here again, there was a significant delay, as we had and I believe Dr. Hoballah described that very well, other cases that were being operated on, particularly for head traumas. So here I'll present a question. You have a patient after major blunt trauma who is hemodynamically unstable, with positive findings including fluid in the pericardium, some fluid in the abdomen, and a large posterior scalp laceration. And you're taking him to the operating room. So what would you do in the operating room? You could proceed with a sternotomy, a laparotomy, a combined sternotomy and laparotomy, sequential sternotomy and laparotomy, or sternotomy, laparotomy, and neurosurgery consultation. Can move on here.
And the results of those, about 1/3 of people would do a combined sternotomy and laparotomy, but most people would probably alternatively do a sternotomy, laparotomy, and a neurosurgery consultation. So we'll find out what you did in a moment.
So I'll describe the situation that we, or the sequence that we went through. Thank you, I'm gonna close that. So in the operating room, the chest, abdomen were prepped and draped, and he was induced by anesthesia, and I would say that will happen at the same time. And at that point, he had severe hypotension, so we proceeded with the chest incision. And here, the sternum was found to have multiple fractures. He had a tense pericardial sac that, once opened, gave away a massive amount of blood pouring out of the chest on the floor, associated with severe hemodynamic instability. And here he received multiple doses of epinephrine and neosynephrine. And this was controlled after multiple attempts by putting my thumb into a hole in the right atrium and then taking care of that hole by suturing it with Prolene sutures. So he received multiple units of RBC despite difficulty in securing blood. And I remember a point in time where we had to give him fluid as opposed to blood because of lack of O-negative blood. After a period of stability, we were starting to close the chest, and we noticed that his blood pressure started drifting again. This was associated with an increase in the abdominal distension. So immediately we tried to call general surgery, but general surgery were busy with other cases. And I proceeded by performing a laparotomy myself. And later on, I was assisted by another general surgeon until the liver and transplantation surgeon joined, and he repaired a large significant laceration of the liver with the sutures that you can see in this picture. Happy with our results, we proceeded with the final closure. But again, at the end of this part of the procedure, the patient became hypertensive again. And we had undraped the head at that point to know that he had fixed dilated pupil. So we realized that we had an undiagnosed major brain bleed. And he was at that point taken to the recovery room where he expired within minutes. And these two pictures will give you an idea about the scene that we had in the operating room that night. So I present this case to just give you these questions that occurred to me. Did we make some diagnostic errors in the process? And probably the answer is yes. Did we make some decision making errors? And probably yes, and that was a result of an error or a delay in the diagnosis. Was this outcome avoidable? In my opinion, I think it was avoidable had we been treating this case individually, as opposed to treating it in combination with all these other casualties that we had at the same time. And I believe if this patient had a constant monitoring and a timely arrival to a CT scan, I believe his diagnosis of a brain injury as well as other injuries would have been made, and he would have received probably a better treatment. And I'm looking forward to your comments. Thank you.
Thank you very much, Jamil, for a very interesting case. We did everything you could for him, but not in the right order necessarily. What would the panel say on that presentation?
Well, you cannot be blamed. I mean, this was a very tricky case. But I think we should remember the words from Donald Trunke, as you know, the American trauma surgeon who fortunately has passed away, but he always stated that the most common death of the unstable patient in a mass casualty situation is the computer tomograph. And that was based on several things. There is limited access to computer tomographs in these situations. And transferring a patient there will be congestion, and transferring a unstable patient to a CT scan, maybe in another department, takes time. So I think you should, as much as possible, try to use simpler diagnostic measures in this case. And I wonder, did you have a possibility to do an ultrasonography of the chest in the emergency room and possibly could diagnose the pericardiac tamponade already at that time? Could you have done a diagnostic laparocentesis, which is a very quick measure to eliminate or verify blood in the abdomen, maybe you could have come to a diagnosis a little bit faster, but of course there's still problem with a head injury that would require the CT. So it really was a tricky case. But could you have done some of these more simple measures to get the diagnosis a little earlier? That's my question.
Thank you for your question and your comments. The diagnosis was made actually in the emergency department with ultrasound of the chest showing pericardial effusion.
Okay.
It did not show a significant abdominal fluid at that point in time, so some minor fluid in the Morrison pouch. But so we proceeded with to take him to the operating room with the working diagnosis of pericardial tamponade. And I believe in situations of like these, fast exam and ultrasound is invaluable in the emergency department for quick diagnosis, like you mentioned. Unfortunately, we didn't have the time to get him to the CT scan to make a diagnosis of a brain trauma or significant brain trauma. We knew that he had a scalp laceration, but we didn't know more about the injury.
Thank you.
Thank you very much. If you'd like to address some of the questions in the Q&A section, we could move on to Dr. Safadi to tell us about caring for the non-injured.
Thank you, Jonathan, and thank you, ESTES, for giving me the opportunity to present our experience with the Beirut blast. So my part of the talk is twofold. I'm going to talk a little bit about caring for the non-injured, and then talk about the role of imaging, particularly CT scan. So mass casualty events or disasters are on the rise worldwide, and in particular in developing countries, especially with the complexity of urban development and the rise in industry and modernity. They're not limited to war or terrorist activities. Many could be from natural disasters such as earthquakes, fires, tsunamis. But a lot are man-made. Examples are train crashes, multiple vehicle collisions, industrial accidents, etc. So in mass casualty, emphasis and resources are immediately focused on the injured, and this includes medical care, hospitalization, financial supports, and a lot of the media is focused on the injured. The non-injured are often not identified and frequently neglected. The non-injured physically can be injured in so many different ways. So to take care of a mass casualty event requires a complex casualty management system that starts at the governmental level and branches down to provincial levels, particular hospital levels, and so forth. This requires a great deal of preparedness, a great deal of resources, a command centers that's central, and communication. On the evening of August 4th, we were not prepared at all for this. Our country has emerged through decades of wars, after wars, and particularly a 15-year-old civil war where most of the infrastructure has been destroyed. We had an influx of about 1.5 million Syrian refugees over the past 5 years. In addition, just to give you a background on what's happening in Lebanon nowadays, we are experiencing our worst financial and monetary crisis with a hyperinflation and severe devaluation of our currency. And on top of that, at that time, were experiencing an upsurge of the COVID cases. So nothing was going well for us on that evening. In addition, our healthcare system is primarily a private healthcare system. Our governmental healthcare system is really not up to par. So Dr. George Juvelekian will talk about caring for the non-injured who were in hospitals and medical facilities. I will talk about caring for the non-injured in the community. So in mass casualty events, the first thing we need to do is provide the non-injured with basic needs: shelter, support, food, etc. We also have to control the spread of disease. Initially, the non-injured do not suffer from mental disorder that comes in at a later stage in the after the casualty, but mental and psychological support is definitely needed. What people need the most is to help them recover the loss, help them mourn, help them pick up the pieces and stand up again, and more importantly, to protect them and provide them with hope. The psychological trauma that have occurred since the August 4th blast is very difficult to imagine or to measure, and will probably suffer from this decades, particularly the younger generation. Many people, as mentioned, have been displaced. Around 300,000 people have lost their homes and had severe property damage. And this picture is one of our family medicine doctors. She's worked all her life with her husband to build a clinical practice. Her clinic has been destroyed, her home has been destroyed, and virtually all of her savings have been destroyed as well. And this applies to so many people we know. As mentioned before by our speakers, 3 of the major hospitals were severely damaged. Several others were damaged to a large extent. And at that same time, many of those hospitals were taking care of a large number of COVID patients. So this Beirut explosion put an extreme strain on an already struggling healthcare system. The economic impact is very difficult to determine. The estimated losses are between $10 and $15 billion. These are the immediate financial implications. The loss of this important economic hub is also will have severe deleterious effects on our economy. Now, this may not seem important to many, but Beirut has been destroyed so many times. It's said that it's been leveled to the ground 7 times and it's been rebuilt. Throughout the decades of civil war, we've had a lot of damage as well. And this one also did not spare a lot of the important heritage that was left in Beirut. Luckily, we had many NGOs, many countries that have flocked in to help rebuild some of this heritage. This is part of the healing process, is to pick up the pieces, but also to maintain some of your memories and some of your important heritage. This happened at a time where our government has failed miserably at all levels. The people who really helped were mostly volunteers, NGOs. The Red Cross has been paramount. We've always talked about the command center. I think the Red Cross was really the hidden soldier. They took care of a lot of the transfers that happened throughout the hospitals, throughout Lebanon, and they were really the unsung heroes in this terrible ordeal. Despite that, we remain hopeful that we can rebuild and build. And again, taking care of the non-injured is sometimes as important as taking care of the injured. So this will, I just want to say something that this particular blast has left a lot of psychological trauma on Lebanese people. For the past year, we've had a revolution calling for a system change, for a regime change. And despite a lot of effort from the population, nothing happened. And unfortunately, what this has led many people to feel despaired. And we are already seeing a big wave of immigration, and in particular in the healthcare system, where a lot of the qualified nursing staff, physicians are leaving in large numbers. And this will definitely have long-term implications. So in conclusion, although enormous resources are directed initially to treating injured individuals after mass casualty events, efforts should be made to identify the scale of collateral damage and provide support to help the non-injured at all levels, the basic survival needs, psychological, mental, to help them recover and build, provide them with a sense of safety and security, and most importantly, to keep looking to the future with hope and optimism. And I thank you. I don't know if I should go on to the next talk or maybe pause for questions here.
I think it'd be good to go on to the next talk.
All right.
And we'll have questions at the end.
So the title of the talk is to scan or not to scan. We heard earlier comments by Dr. Sten on the potential perils of scanning individuals. But this is how the hospital looked at 6:10 p.m., a couple of minutes after the blast. I was in a meeting, and as I walked down, the hospital was again severely damaged. So as I walk into the emergency room, within 10-15 minutes, we were flooded with so many patients. And at that time, many of the doctors, because of the COVID situation, had been leaving relatively early. So the hospital was really almost empty of physicians and a lot of the nurses. So we didn't really have a lot of human resources to triage patients. So I'm going to present this case and maybe hopefully spark some questions. So this was a 43-year-old patient who presented with left-sided chest and abdominal trauma. He had no loss of consciousness, no vomiting, no trauma to the head. An ER assessment was done with the airway, breathing, circulation assured. He had x-rays of the upper extremities, which confirmed finger fractures. His vital signs were normal on presentation, and these were his vital signs at around midnight. His blood pressure was 150, his heart rate was 89, he had good saturation. But on physical exam, because what we did is we admitted a lot of those patients and we kept examining them every hour or so. He had initially a soft abdomen, no tenderness, and he was admitted for observation with a plan to repair his finger fractures the next day. So we did a chest x-ray which showed limited pulmonary expansion with bibasilar volume loss. He had an 8mm left apical pneumothorax and bilateral blunting of the pleural recesses. A few hours later, he had a distended abdomen. He complained of diffused abdominal pain and he was tender, especially in the left upper quadrant. And his vital signs started changing. His heart rate went up to 104. His blood pressure dropped a bit to 105/70. And at that time, we did a CT scan, which showed this splenic laceration. The splenic laceration appeared to be confined. There were no evidence of hemothorax. And their main reason for doing the scan was because of his pneumothorax. We wanted to exclude a left-sided rib fractures. So over the next 6 hours, he had increase in his left upper quadrant pain. His heart rate reached 120 and his blood pressure started dropping. And at that time, we took him to the OR. We had a quick stop in the CT scan as we prepared them. And you can see now a lot more blood in the abdomen. His spleen laceration and hematoma is expanded. And he was stable enough so I could put the scope and the laparoscope, and I was able to do the laparoscopic splenectomy, and he recovered. Now, again, with the large number of patients, we didn't really have a lot of time to question patients on how they were injured. We had to really do a very quick assessment just to make sure that their glaucoma score was high, that their hemodynamics was fine. So we had a problem in linking the mechanism of injury. But after the event, I'd asked him what happened, and he said, well, I can show you exactly what one of his sons told me, well, I can show you exactly what happened. And he showed me this video that I will share with you. So when you look at the scar here, these bystanders are just hearing about this explosion. And you can see this individual coming from the far right of the screen, hiding close to the car. And finally, this big glass pane will impale him on his left side. And this is exactly what happened with some of these injuries. They were not only limited to blast injuries by the blast, but they were also caused by a lot of these falling objects, etc. So obviously, when we screen and triage patients in a mass casualty, we have to focus on the airway, breathing, and circulation aspects of trauma. As mentioned earlier by Dr. George Dabar, it's very important to quickly screen for any head of injury with the glaucoma score and focus on the important things, which is airway and control of hemorrhage. And beyond that, we had to promptly triage patients either to OR directly if they were unstable, or to the intensive care unit when we felt that they had severe head injury. Now, the secondary survey is time consuming, and we didn't have a lot of doctors to take care of it. We don't have really access to FAST. We don't have a lot of emergency room or surgeons who are trained in FAST. And the x-rays take a long time and they have a high rate of false positives and false negatives. the physical exam findings when you don't have good documentation is difficult to track. So even if somebody examined the patient, how do you transmit this information from one physician to the other? And that will lead to a lot of missed or underestimated injuries. So here in fact, after this incident, it made me realize that we should focus on mass scanning and try to come up with strategies to make scanning more time efficient and safe, because that will help us identify potentially life-threatening injuries, particularly craniofacial injuries. And it's a documentation that all healthcare workers can access simultaneously. And in addition, I thought about this. Radiologists can read and interpret images even when they're not in the hospital. So when you're faced with a mass casualty event and you don't have a lot of physicians, you can within minutes have a lot of radiologists that can help you with this. So I'll show you some of these pictures that we saw on the pneumothoraces, the head and neck injuries, and scanning really was very useful for us. I didn't see a lot of things written in the literature. Now, this was an interesting study by a German trauma center where they simulated a mass casualty event, and they figured that they can scan up to 6 patients per hour. And then the time that took longest was actually to interpret the images, which was in the order of 20 minutes. But scanning can be done quite efficiently, and the patients really spend 6 minutes or less in the scanner. So our chair of the Department of Radiology, Dr. Daniel Mahfouz, who's with us today, I don't know if there's a way we can get him on board, but his team did a fantastic job. They've scanned over a 9.5-hour period, 74 patients. Those out of the 400 patients who came to us using 2 scans. One of them was not functioning in the first hour. With this calculation, I figured it took almost 15 minutes for patients to go in and out, and most of these were total body scans. We did not have any death or serious morbidity from a missed injury. We had few deaths from severe head injuries. And the preliminary readings, again, Dr. Mahfouz takes credit for this. They wrote down on the patient's skin. So the patients who came to us to the OR, we could tell from the skin if they had a normal brain CT or they had a spleen injury, etc. So that was very helpful. So I'm opening a subject which is certainly controversial, and I'm sure we're going to get a lot of questions, answers. And again, Jonathan, if it's possible to get Dr. Mahfouz on board, that'd be great. Thank you very much.
Thank you, Bassem, for that very interesting and thought-provoking pair of presentations. I still haven't managed to find your colleague to be able to invite him to participate. Okay. Okay. Would anybody like to comment? A patient who becomes hemodynamically unstable and has a couple of CT scans, I'm sure that that'll provoke some thought.
Jonathan, if Sten can deal with that question, and I deal with the non-injured one, that may be quite useful for me.
Okay, go on.
If I take you back to the first presentation when you talked about the non-injured patients, I've got a couple of questions here. Is what about survivor reception centres? Were they designated? And how do you register somebody that is non-injured? Also, what about the non-injured rescuers and also the hospital staff afterwards? How are you recording those?
So the first one was on the survivors. You meant the documentation?
Sometimes in these type of incidents, countries have survivor reception centres. One of the problems is people actually knowing where to go. They know the injured are going there, but where do the non-injured go who have problems? So they designate very highly survivor reception centres. Do you have those?
Well, nothing was organized per se. A lot of the NGOs did that. I don't have a lot of information about that area in particular.
No, that's okay. That's part of a plan which can be lessons learned maybe later.
Absolutely.
What about the rescuers and the hospital staff? Were they looked after as far as being non-injured, but they were traumatized as well?
Yeah, well, Dr. Hoballah alluded to one thing which is important. A lot of us were unable to contact our family members when the blast occurred. So you can imagine the scenario where you're taking care of a lot of injured and you have no idea if your wife is okay or your kid's okay. This was certainly traumatic. A lot of our health, or not a lot, but some of our healthcare workers actually lost loved ones, and they didn't really know about it until the next day. And again, you know, the trauma of the Beirut blast is enormous, and it not only affected healthcare professionals, it just affected the whole population.
Yeah, thank you. It's very difficult, but thank you for raising that question. It's a really important question. We've got to look after people later. I think Sten might be better answering the next part of your presentation. Jonathan, is Sten there?
Sten, do you want to comment?
Yeah, I think you're muted, Sten.
Sure. Hear me now?
Yes.
Yes, I think the first case, the second case you presented there is certainly subcapsular lesion, and that's very common that the splenic ruptures come delayed, appear delayed as it did in this case, and it's very good that you didn't miss it, but really followed up this patient. When you talk about massive CT scanning, I think we must be realistic. I think there are very few hospitals in the world today that will come up with such resources. You can do such a massive CT scanning to so many patients. There will be a risk of congestion, and there will be a risk of delay. So I think we really must make efforts to use other simplified diagnostic procedures as much as possible. And I think ultrasonography in the emergency room should really have high priority. There should be a scanner in each emergency room. You really could do that, and emergency physicians should be able to do this themselves without relying on X-ray. Then you can make a lot of diagnosis in that way. And do not forget the diagnostic peritoneal lavage, which we do not use very much in normal life, but that really can be helpful in situations like this. But of course, if you can get the resources to have a massive scanning like this, just congratulations, that is good. But I think we have to look at how it looks around the world. So I think it will be difficult to reach that everywhere. When I saw the first presentations, I came to think about the international assistance. I talked actually last week with Johan von Schreb, the WHO coordinator in Beirut, about the experiences there, and I wonder how you feel about that. I heard that the field hospitals coming in, being devoted to take care of primary trauma management, they came in too late. They hadn't very much to do. But the hospitals that really were helpful for you was those devoted to support in the aftermath of the disaster with the support of the ordinary healthcare, as the Morocco field hospital was stayed for a long time. So that illustrates again a lesson that has to be learned every time, that you really have to coordinate the resources according to the real need of the suffering country. And I wonder how you feel about that. How you managed to do this in this case, and what we should do to improve it.
Yeah, well, our healthcare system is actually not bad. So despite the fact that 3 of the major hospitals were damaged, we still had capacity to take care of the injured, particularly since 90% of the injuries were really from just glass shrapnel. So they're mostly like soft tissue lacerations, etc., that many small hospitals could deal with. Ideally, in an ideal setting, that should apply to any urban area. There should be a governmental ability to erect a field hospital within hours. That's really the key. Otherwise, most of the field hospitals that were erected, you know, like you said, they came in quite late, a week or 10 days later, which were really not helpful for taking care of the trauma, but they may have helped take care of some of the other injuries, perhaps delayed, maybe take out some sutures or do some bandages, etc.
Okay, thank you very much, Bassem. That's a very provocative case presentation, and you've got a lot of questions there to answer on the Q&A system.
Okay, I'll start.
You might take a while. Right, can we move on to George Juvelekian for presentation on caring in catastrophe and evacuating your hospital? George.
Thank you, everyone. Good evening. I wish to thank the organizers for this amazing effort to bring us all together. And I have to say that even though I've lived through this thing, you know, looking at it from different angles always makes you wonder how you can maybe prepare for something like that. I think all my colleagues did a great job illustrating the different aspects of what happened that fateful day. But I think, as they also mentioned, St. George Hospital was one of the most severely hit hospitals in that catastrophe. And I think despite all the heartache and everything, we did get through it with, I want to say, less than anticipated damage, and I'm going to try to shine upon some of those. So essentially, this was done on a day in August after 6 p.m. and in the midst of a pandemic. Those three different factors probably were kind of the silver lining of this disaster. Especially at St. George Hospital. So St. George Hospital is a mere 900 meters, less than a kilometer straight shot from where the blast, and it's on a hill. So Ashrafiyya, which is that part of Beirut, is sitting on a hill. So essentially, it kind of took the full brunt of the blast that day. This is a hospital that's been around for over 140 years. And this is the original hospital. You will see it now. It's still there to a large extent, albeit not exactly the same looks, and definitely not after the blast. I have to disagree with one thing that Dr. Dabar said. He said that none of the hospitals is ready or accustomed to receiving a huge amount of patients at one time. I have to say that although he's correct, I think the difference is with the August 4th blast is that I don't think anyone could have prepared the whole country to be able to receive a flood of patients all at once. So I had colleagues, physicians, that had to travel all the way up north, about maybe 50 kilometers north of Beirut, just to get into a hospital where they could get first aid. So I think the magnitude is that it kind of affected all the major hospitals all at once. And this is a reminiscent picture from the war where we had essentially, you know, blockaded the glass windows with sandbags, and even then some of them were shattered and were covered with plastic. You know, pre-blast, this is our hospital. It's a 400-bed hospital with its own helipad. You'll see one of the cameras in a bit looking specifically at that. And if you look at the left-hand side of the picture, you will see the red tile building. This is the original hospital from over 140 years ago. And the hospital, of course, is always getting renovated, and it's almost all you know, done with major renovations. And this is part of the lobby and a typical patient room. And then you have this, right? So all my colleagues alluded to the fact that the majority of maybe the injuries were glass shrapnel, and that's very accurate. So we didn't really see that many, you know, burns, but we saw just blunt trauma from the blast, so fractures, and of course the shrapnel. And this is our helipad. So this is the camera right overlooking the bay and the helipad, and you will be able to take a look at the entrance in a few seconds, then the emergency department, and finally the very last a couple of seconds is the nursery, where one of our you know, nurse heroes was there and did a kind of a small miracle on her own. So this is the main entrance. And you can imagine the magnitude of the blast pressure. This is the same thing, except it's just a few feet out. And this is the outside entrance. And this is the front of the ER. And here, this is the inside the emergency department, one of the sections of it. And this is the also another section with the nursery. This is the nursery there. So you can imagine the amount of damage. This is the emergency department next to it, right after the blast. I'm sorry, this is the front lobby because we're still renovating. And this was my clinic. So, and I was there at 6:07 when the blast occurred. And even though I wasn't directly facing the blast, I was kind of face sideways. The glass and the aluminum frame just came out and flew all the way in, hitting me on the side of my head. I was very fortunate because it was just front with front fractures and facial fractures, not brain trauma. But this is from my intensive care unit, and you can see the amount of glass and the damage to the building. And this is a typical hallway. This is my ICU hallway in the center. On the left-hand side is one of my regular ward rooms, and you can see from the window, you can see the old building, the old hospital building, and the damage is sustained as well. So just keep those pictures in mind, because when you are evacuating your hospital, you have to go through all of this, and it's of course extremely hazardous with a lot of potential for additional injuries. And mind you, like my colleague said, this was at 6:07 p.m. on an August evening, so days are a bit long. So, but it was going to be night a couple hours after that. Of course, the damage was across the whole building. This is a hospital that never went offline despite 15 years of civil war. This was the very first time in its history that it went completely offline for exactly 20 days. And 20 days, even though they looked like a long time, they were amazingly short, considering the amount of injury and damage that the building sustained. This is one of the entrance lobbies, and again, you can see all the ceiling tiles and how they themselves formed like flying debris, like what Bassem was alluding to, that caused some of the injuries. This is afterwards. So evacuation, how do you evacuate something like this? This is a hospital that had around 200 inpatients at the time. It had 13 ICU patients. The COVID area, which was a completely sealed area, had, I think, if I recall well, 16 patients in it. And of course, you had the hospital personnel, and you had the visitors. So this is the hall that the path that leads to the emergency department, and this is one of its back entrances. So people were being evacuated whichever possible way was there. So on the fallen tiles, ceiling tiles, on broken doors, the blankets carried like these on stretchers, etc., etc. So all different means were used. This is the entrance to the emergency department, and you have to keep in mind an additional couple of things. So first off, this is a hospital where people came to. This is a tertiary care hospital. So people were flooding into the hospital to get first aid, like what Dr. Dabar and Dr. Hoballah and Dr. Safadi explained before in the past hour. But the difference is that we were offline. We were completely out of commission, and we were doing first aid in on the floor, in the underground, in the entrance of the emergency department, and a nearby. This is right before the blast, DR, and this is right after, right? So, and in the parking lot that were right next to the hospital. This is the parking lot I'm alluding to, and it's right across the main entrance to the emergency department, and it was turned into a makeshift hospital, essentially. I was talking to you about that nurse, our nursery nurse, essentially, and she managed to get all 3 triplets, newborns, to safety. But to be able to do that, she had to walk 5 kilometers, because all the roads were closed either by debris or fallen trees or cars that are damaged or fallen glass and debris from buildings, but also by cars that were just left there idle because you just couldn't move front or back. So getting patients, our patients, close to 200 some patients, well, close to 300 altogether, because we had 100 of our hospital employees that were injured, getting them all to other hospitals to get first aid. That required all different kinds of innovation. And in this situation, I have to say that people were amazingly up to standard and up to the task, because anyone who had means of transporting an individual did that. They did it without knowing who they were or where they came from. They just got them to an area where they could be cared for and for safety. This is one of my residents, and I think there is subtitles so you can see what happened.
So I had to get up. حطيت ايدي هون على ضلوعي وصرت قد ما في ساعد العالم، يعني طقتي صرنا نقطب الناس، بتشوفي مناظر ايدين روس ناس بالارض. اضطرينا نعمل انتوباسيون لمرضى على ارض الطوارئ بالارض بلا ضوء بلا شيء. بتذكر كثير منيح في مريض كنت حاطط سيلولاري بتمي كان شو هيك وعم ضوي الفلاش على تمه وعم اقطب له من هون ومن هون من رقبته، ومرته فوق راسي عم تصرخ وتعيط وترجاني انه بليز بليز بليز. هو عم ينزف بشكل كثير مش طبيعي يعني. بعد نص ساعة صراحة دخلت وغبت عن الوعي بالطوارئ.
So in summary, the evacuations involved over 180 inpatients, 30 intubated ICU patients, and the COVID area, and over 100 injured hospital employees. It's interesting, Dr. Safadi was talking about caring for the non-injured. I have to tell you a piece of information that I got from our psychiatry department recently. Of course, you know, a lot of the hospital employees, they live close to the hospital. And of course, that's the area that was ravaged by the blast. So of those 100 hospital employees that were injured, a quarter of them had people in their family die in that blast, in their homes or outside the hospital where they were living or where they were visiting, etc. And the second is that St. George Hospital suffered by itself at the moment of the blast about 10% of the total death toll. So we had 17 patients and employees that died immediately. 4 of them were our nurses that were mostly on the 8th ward, caring for some of the COVID patients and the ICU patients. All means of evacuation were used or improvised. A crisis unit immediately formed, had several tasks, one of which was, of course, to secure all the hazardous areas. So we have 14 different elevators. All the elevator shafts were blown and blasted open, all of them. So you have 14 elevators, 10 floors, all of the shafts were open and they had to be secured. Some people from the maintenance had to secure the fuel and oxygen supply tanks. Electrical sources also. Something I wasn't aware of is that there was a kind of a mini relay electrical station underneath the hospital back entrance, the service entrance, and that also sustained some damage, and there was concern that there was going to be a major short that would cause potential fires. So those had to be taken care of, and people had to keep their cool to be able to achieve that. Makeshift field hospitals were established in the parkings around the hospital and in front of the ER entrance. However, we ran out of first aid supplies because, well, some couldn't be reached, and the rest were just used because people were still flooding into the hospital, not knowing it was off service. All patients were secured to less damaged facilities, and an assigned team took the job of calling the following day. Dr. Dabar was talking about keeping track of people, so we did that. people were able to keep track of all the names of the patients that and injured that we had to transfer elsewhere. And the following day, they were all called individually to make sure that they were cared for. And the evaluation effort took about 8 hours. Like I said, power was out. One of the lessons learned was to figure out how to beef up and empower and improve our emergency power sources, because the effort took about 8 hours. So you're talking about till 2 a.m. Until we were able to evacuate all patients to safety. So some of the lessons learned, and there are many there. You can never claim you're completely ready. So even this kind of scenario, which can seem completely outlandish, obviously wasn't impossible. Disaster planning was expanded to include such scenarios. Ceiling tiles are being replaced with non-metal ones as we speak. Emergency lighting was beefed up and placed on every floor with redundancies. Stocking with first aid supplies, additional emergency kits, defibrillators, including placement outside the ER premises in different departments and sections are being implemented. An additional communication system is being also beefed up, because we had a kind of a talkie-walkie thing, a two-way, because as you know, at the moment of the blast, and my colleagues alluded to that, nobody could get hold of his family. Just to make sure that they're okay. And the same applied for us by and large. So a system to communicate amongst the crisis team and the emergency people were to be implemented. And I think this is already taken care of. And like I said, my colleagues did say, most of the injuries were from glass shrapnel. So laminated glass tiles are to be used with the future refurbishments. And I think I will leave you with something that that was my clinic.
On the side of my face. Professor George Juvelekian was in his clinic at the time. He told me he just finished a consultation. Had my colleagues not picked me up from here, I could have led to that. Who knows? We should be proud of what we've done. What this hospital did in 8 hours, evacuating over 300 patients to safety, despite the lack of power and glass everywhere and unsafe environment and no resources, is a miracle by itself and speaks to the greatness of this people.
So today we are back on track. The hospital reopened its doors 20 days after the blast. Started with, of course, the three main areas: the outpatient clinics where patients come, the emergency department, which you have to do it, and the makeshift ICU was embedded within the ER. The surgical theater, one of the small also maybe blessings in disguise is that we learned from the Civil War to keep some of our coveted resources underground. So the operative theater, 10 rooms, is underground in the third sub-basement. The diagnostic a theater, so CT scans, MRIs, PET scans, etc., sets in the first sub-basement, and that's an area that was not damaged much by the blast. And also the laboratory was in the first sub-basement and in the GF ground floor, which wasn't that much damaged compared to the rest of the floors. The capacity climbed from about 40 beds to around 120 today. We did use a hospital that has been off service for the past 3 years. We kind of took over part of it and changed it into a COVID ICU. It's a 14-bed kind of a COVID ICU to try to preserve the safety of the main hospital, because separating patients in the main hospital currently is more difficult because of the limited resources and, of course, the amount of damage and the time required to do the safety measures. All the activities that were ongoing prior to the blast in regards to the Joint Commission International certification, other issues pertinent to our St. George University of Beirut have resumed essentially, and we hope that our hospital will be poised to become one of the most advanced and best equipped university hospitals in the coming 18 months. With that, I thank you for your attention, and I'll take your questions.
Thank you very much for that, George, sharing with us what must be everybody's ultimate nightmare scenario. You mentioned that you managed to evacuate all the patients within 8 hours. Where did you evacuate them to, and how was that coordinated?
Yeah, so essentially, well, Dr. Dabar and Dr. Safadi need to be thanked for some of that effort, because some of our patients, some of our colleagues, physicians, they went, found their ways to Hôtel Dieu de France, to other surrounding hospitals, to AUBMC, and to anywhere they could get access to. So one of my colleagues, for example, arrived at Hôtel Dieu and immediately went to the operating theater because he was bleeding from an arterial injury. So like I said, it was something that was done on the go, whichever way you could, to get people to the closest facility that would accept them. I personally was shuttled to Mont-Liban Hospital, which is a hospital that's not too far, and where I got my scan done to make sure there were no intracranial hemorrhage, and got my sutures done, and then I was able to go back and be part of that effort to some extent, albeit less than some of my colleagues. But again, this was something that was done on a case-by-case basis, and whichever means possible to any facility that was able to care for them.
Was it coordinated at all? You said that the patients were then followed up the following day.
Yes, so essentially all the patients that were to be sent to other facilities, their IDs, their numbers, and their location were kept in a written log, actually, because as my colleagues said, all the electronic medical records were off limits. As a matter of fact, that's one of the things that we learned from it, to have also backup for our electronic medical records, and to be able to come up with a system that would be electronic, that would allow us to maybe cater for such patients and provide identification the best way possible. So that list was available to a set of volunteers. Some of them were my fellows the following day, and they were calling all those different facilities and making sure that patients were taken care of, they were safe, and they were being cared for in their facilities.
Thank you. Can I throw it open to the rest of the panel? Sten.
Well, just a short question. Do you ever train practical evacuation of hospitals? That could be of some help in a situation like this, even if you cannot prepare for everything.
So the answer is yes. We have a disaster plan. We have actually a section called the Lebanese European Emergency Medical Association of sorts, and it kind of a train the trainer. So George Saad, who is the head of this effort, coordinates with different organizations, including the United Nations, the UNIFIL, on disaster management, including hazardous material and pandemics and viruses and major fires, etc., and flooding. But I don't know if anyone really of us foresaw that level of devastation. I mean, to have our hospital completely go offline, that's a hospital that's like I said, it's in a T-shaped 10-story above ground, 5 stories below ground, and it hosts 400 different beds. That's different from the next building. So to have all this go completely offline like this was unforeseen, I guess, and that's something that we're learning, and we learned from this disaster.
Okay, thank you.
One thing I will say, Jonathan.
Bob?
Yeah, one thing I would say, the logistics of what they achieved is absolutely amazing. The questions I was going to ask, you actually asked. But I just wonder if you could rerun that. Is there one thing that you would have changed on what you did when you made the choice to evacuate?
Well, the only thing I regret we did not have was that there wasn't a set of emergency stairs outside of the hospital that would have been used to evacuate people. We were transferring and transporting patients over rubble and over debris in hallways that were completely pitch dark and on stairs, because all the elevators were completely blasted open. and we had to do it under very difficult circumstances. So that's something that is in the making, but it's easier said than done, because, as you know, Beirut is a very crowded city, and to be able to do something like that, it requires a lot of effort and logistical. Well, I have to also say something that maybe will be more relevant today. The initial estimate of the amount of damage that we sustained is upwards of $45 million US. So for one single institution to be able to support something like that and still carry on, that's by itself a difficult feat to achieve, and another challenge. But also, like my colleagues said, a lot of support has been, pouring from all over the world in different means and ways, in terms of, donations in kind, even in monies and in expertise. So we have a lot to draw from, and it kind of allows you to, when you do something like that, when something like this happens to you, it allows you to restart the hospital the way you want it to be. That's one of the few things that separates us, for example, from AUB, my alma mater, and Hotel Dieu, because they were not damaged to that point. I'm sure they would want to do a lot of things, major things, and that they're hindered by the fact that they are doing it on the go. St. George Hospital was damaged and went offline, and we took those 20 days to come up with plans to rethink and plan and restructure everything, to comply with LCME and JCI, and to make sure that all the security measures and safety measures and access and all this is going to be taken care of. So if you also want to call it a silver lining, I guess that would be it, that we can start afresh, because the damage was so great. But I think that also this is important, because even when you think that you want to do that, you have an obligation towards your patients, your chronic patients, your dialysis patients, your chemo patients, your chronic COPDers, and so on and so forth. I'm a pulmonologist, so I'm the head of ICU. So, just imagine how difficult. We had 13 patients intubated. If we didn't have a relic from from our civil war to have backups, energy supply, and have UPS for all our ventilators, those 13 patients would have all died. They all survived simply because you could get to them in time and hook them to batteries and other things, because their UPS emergency system was still functional.
Well, I just think you did an amazing job. I cannot believe what you did. We got so much to learn from you. I'm looking forward to hearing some more about it.
Thank you.
What a task. Fantastic. Thank you very much for an excellent presentation. The films were unbelievable. Thank you.
Thank you.
Thank you, Jonathan.
Okay, thank you. Ali, you want to comment?
Yes, just one comment. What I learned from this experience, I believe this region is on a disaster fault line for the foreseeable future. And I think it's time for the 4 major hospitals in Beirut to basically consolidate our communication together and to come up with a joint disaster plan. I believe this is the lesson learned. If we want to do something about it, let's join forces and do that.
Yeah, perfect.
Definitely.
I was going to ask you, because we could go on talking for hours and hours well into the night, but we're going to have to draw the webinar to a close. What I wanted to do was to ask all of the members of the panel, certainly all the people from Beirut, what they've learned from this and what they would change next time if they had the chance. Ali.
Yeah, I mean, I just
answered it, haven't you?
Answered this question, but I also want to stress a point that that Dr. Safadi alluded to, which is the well-being of the healthcare worker. As an example, I'm still under the trauma of this day. It took me around 45 minutes to know whether my son were safe. They were on their own at house with their nanny. And then at one point in time, I actually discussed this with my chair 4 or 5 days later. At one point in time, I was about to leave the emergency department because when I realized the calamity of the situation, all I was able to think about are my son safe or not. And I think I'm still traumatized by this issue, and I think there should be some form of program to help healthcare worker to overcome such a psychological trauma.
Yeah, if I may, yeah, I agree, Dr. Hallal. If I may, though, I would say, and I think all my colleagues will support me with this. The biggest problem we face in Lebanon, I think, is the fact that we're such great individuals, maybe, or we're so good as private institutions or single entities, that we never really collectively, as Lebanese, took the time or effort or maybe the decision to have a system, a countrywide system, a government-led system, a public health system. I mean, just imagine that if we had an emergency medical system like what is present in the US or in Europe, the majority of people could have been cared for locally where they were because they were minor injuries to a large extent, or they would be cared for via a first aid right there at the blast site or at the injury site. We would have been able to maybe get people to safety or to proper care in a better structured manner had we, came up with a statewide, countrywide, state-sponsored evacuation and disaster plan. So I think what we need to do as Lebanese, we need to make sure that our public health system is up to par, and that's unfortunately far from the truth.
Okay, Dr. Hoballah, what would you change if you could next time? What would you do differently?
I think, again, I would think that the two most important aspects are communication and triage. And I think the more you can plan ahead and rehearse that so that you can be prepared for anything that happens, even if the usual modes of communication are broken, that you have your system active irrespective of that. With that, then you go to the triage situation that you have already your zones arranged, who's going to lead one zone, who's going to take care of the other zone, where is everyone going to be, guidelines for your triage so that everyone's already going into the right direction. And I think these are key issues. Imagine if this thing happened to us in the middle of the day when we had all the operating rooms all filled and on a rainy day and no transportation. I mean, this could have been even 10 times worse. But if you have a good system, a good triage, and a good communication, I think you can get by with least amount of damage.
Thank you. So you'd like to move the triage as far away from the hospital as possible?
Yes, I mean, even start from the triage from the beginning. It was mentioned by an earlier speaker. I mean, some injuries can be handled on the site, on the ground, or referred to other hospitals, so that the key hospitals that can have to deal with the major trauma, the major life-threatening trauma, are dealing with the life-threatening trauma and not being engaged with the skin lacerations on the hand or arm or forearm. And even within that same hospital, within that hospital, there will be zones and faculty and staff dealing with the lower level injury and other area where you need, and the major injuries are being addressed by those who are most expert in them in those specific locations.
May I?
Please.
Yeah, so what did I learn from this? We could have an earthquake, soon in Beirut. An earthquake will certainly cause mass casualties. I don't think hospitals or medical facilities are equipped to deal with mass casualty. So I think that there has to be something central, led by a government, maybe the military, where field hospitals are erected, shortly after. Otherwise, hospitals cannot deal with this kind of injury. Now, as far as short or small-scale injuries, let's say with a car accident or something like this, what I wished I had at the time of resuscitation is like a built-in camera, like the ones you use to videotape I don't know what you call them, the video cams that you put on your head. I think this might be a good alternative. I think the military uses them when they do like these military operations. So sometimes when you're dealing with multiple casualties, it's good to document what you're doing over and over when you're seeing patients. That could be something. The other thing we don't use enough is technology. I know when you have a mass casualty, you shift from technology to paperwork. But if you have a reliable technology that can help you scan patients quickly with IDs, that would be helpful.
Okay, thank you. Dr. Dabar, what would you do?
What George talked about earlier, actually in our presentation tonight, nobody talked about what was going on the field and the lack of emergency medical service on the field, what was really important that was missing. We don't have it as a national public policy or public health policy. So what we would have liked to save more lives. We are not far from the place where this happened, from the blast. You know, we didn't see a lot of blast injury. We've seen a lot of orthopedic injury, etc. Because probably those people, nobody was there to carry them. I can tell you that people were coming on motorbikes to the hospital. There was the roads were not clean to get the ambulances and the people in the car. So the problem, we didn't talk about how to organize the city and what was going beyond the wall of the hospital. And that is a shame because this is the government responsibility, and unfortunately we're lacking government in this country.
Okay, so a lot of work to be done there. Dr. Borji, what would you like to see done differently next time?
So again, I agree with what was mentioned by my colleagues, and I think everyone agrees that no matter how prepared you think you are, you can never be prepared for something of this magnitude. The psychological impact was humongous on healthcare workers and people of all sorts of life. And I think this webinar revived, I think everyone agrees that revived this horrible experience in our mind and hearts. I think I will also reiterate the importance of triage, documentation and coordination. And I think in a country like Lebanon, you have to rely on private institutions and not the government to form I think that coordination between major hospitals would be a great idea. Reinforcing the infrastructure, if you have the means to do that, even if that means a lot of redundancy, because we found out that we are short on CT scans, short on ultrasounds, on staff, on rooms, and I think this is what I can think of at this point.
Okay, thank you. You have the difficult task of being the last person to comment. I think as I said earlier, we could go on all night discussing this. There are lots and lots of things that we haven't even begun to touch the surface of. But I'm going to have to draw it to a close here. Thank you very much, all our fantastic speakers, many of whom have relived what was quite a harrowing experience. Thank you to our other panelists and to our webinar team. This is the last webinar of the year. We will be starting again around the middle of January. But I'd just like to once again thank everybody for taking part, our great speakers, our great panelists, and our great audience for the questions that you've asked. Thank you very much. Goodbye.